students, I am Dr. Harmeet Goel. I have done my MBBS from Lady Hardinge Medical College and post-graduation in Obs and Gynae from Safdarjung Hospital, Delhi, and hospital management course from National Institute of Health and Family Welfare. So today I have decided to release a video on the Obs Gynae NEET PG 2020 recall questions. Although I am late in releasing this video, but many of my students, they want me to take up the questions of NEET PG 2020 for their preparation, as the exam of NEET PG 2021 is nearly approaching and only few months are left. So I decided to release this video today. You can follow me on my YouTube channel, Instagram.
So student, I'm sharing my screen. So I'm discussing the NEET PG Obs Gynae 2020 recall questions. So the first question in this regard is 35-year-old female primary gravida with history of IVF, in vitro fertilization done, and having diamniotic dichorionic pregnancy at 38 weeks. First twin baby is in breech presentation. Blood pressure of this pregnant lady is 140 by 92 millimeters of mercury. Urine albumin is 1+. Next line of management. So the options given are immediate cesarean section, induce at 38 weeks, watch blood pressure and terminate when the blood pressure gets elevated, watch for blood pressure and induce on expected date of delivery. Let us see this question. Number 1, 35-year-old primary gravida. Risk factor number 1. Risk factor number 1. History of in vitro fertilization. Again, we take it as a precious pregnancy and having a twin pregnancy. Another risk factor, twin pregnancy is considered as a high risk pregnancy. Number 4, high blood pressure. Okay. So in this question, they have already, even if it was not the high blood pressure, even if it was not in vitro fertilization pregnancy, still the first baby breech in twin pregnancy is an absolute indication to perform elective cesarean section at 38 weeks. But they have given you plenty of hints in this question. So she is 35-year-old, that is elderly primary gravida, in vitro fertilization treated pregnancy, so it is a precious pregnancy, then twin pregnancy, then high blood pressure and first baby breech. So I would like to take this patient for immediate cesarean section. First baby vertex, maybe you think of a normal vaginal delivery. So all the other options are ruled out. Moreover, at 38 weeks, the high-risk pregnancies needs to be terminated. Okay, and no way the high-risk pregnancies are to be continued till term. So I would like to take this patient for an elective cesarean section without any further delay at 38 weeks. Now, what are the indications of doing a cesarean section in twin pregnancy? Number 1, in the twins, when the first baby is breech or transverse line, that is, first baby in malpresentation is an indication for cesarean section. In breech, there is risk of asphyxia. In transverse line, if you allow normal delivery, it will land up in obstructed labor. So only indication for a vaginal delivery in a twin pregnancy is first baby in cephalic or vertex presentation. Now, another indication to perform cesarean section preferably if it is monoamniotic monochorionic twins. And number 3 is conjoined twins. Conjoined twins because it will land up in obstructed labor. Monoamniotic monochorionic twins because there is a single placenta which these babies are sharing and there is a risk of twin transfusion syndrome. So preferably, I would like to take up the patient for elective cesarean section. So here the question, they have given you plenty of hints because they want an immediate answer as cesarean section. Next question. A mother brings her 16-year-old daughter to gynae OPD with complaints of not attaining menarche. She gives a history of cyclical pain abdomen. On further examination, midline swelling is seen and per rectal examination shows a bulging mass in the vagina. Probable diagnosis. Let's see the options. Imperforate hymen, MRKH syndrome, that is Mayer-Rokitansky-Kuster-Hauser syndrome, that is Mullerian agenesis, and associated skeletal and genitourinary anomalies. Third is transverse vaginal septum, and fourth is vaginal atresia. Now, 16-year-old girl has not attained menarche. So this is a case of primary amenorrhea, okay? And there is a history of cyclical pain abdomen. So she has not attained menarche, but there is history of cyclical pain abdomen. Cyclical pain abdomen. This signifies that ovulation is occurring and ovaries are normal. Ovaries are normal and it is normally producing estrogen, progesterone, because that is why cyclical pain abdomen every month. On examination, there is a midline swelling, and per rectal examination, there is a bulging mass. So there is the midline swelling, and in per rectal examination, there is a bulging mass. So bulging mass, that means you've already ruled out that there is Mullerian agenesis because uterus is present. You can very well see in this case, uterus is present because there's a bulging mass and ovaries are normal. Fine. So we have to rule out imperforate hymen, transverse vaginal septum, vaginal agenesis also has been ruled out. Students, imperforate hymen and transverse vaginal septum. Imperforate hymen and transverse vaginal septum both can cause cryptomenorrhea. Cryptomenorrhea means features of menstruation present without external bleeding. Because the cause can be imperforate hymen or transverse vaginal septum, that means the hypothalamus, pituitary, ovary, uterus, all are functioning normally. They are producing hormone GnRH. It is producing FSH-LH. Ovaries are producing estrogen, progesterone. Uterus, endometrial lining is formed, endometrial lining is shedding, but there is no visible bleeding. So this menstrual blood will collect in the vagina, in the cervix. That is called as hematocolpos. In the uterus, hematometra. In the fallopian tubes, hematosalpinx, and there is a retrograde spread to the pouch of Douglas. So the bulge which you are feeling is hematocolpos. So students, imperforate hymen is more common than transverse vaginal septum. So I would like to mark the answer as imperforate hymen, which is the most important cause for congenital cryptomenorrhea. Congenital cryptomenorrhea. Next. Which of the following is not estrogen dependent pubertal change? Hair growth, menarche, vaginal cornification, cervical mucus. So let us see. As you have studied, estrogen is a main sex hormone in the females and testosterone is the main hormone for puberty changes in the males. Source of estrogen is the ovaries. Ovaries is releasing estrogen, and estrogen is responsible for growth of the breast. Estrogen acts on the uterus and leads to proliferation of the endometrium, and then the dominant follicle of the ovary secretes progesterone, which causes secretory changes. If the fertilization do not occur, this ovum is shed off and endometrium disintegrate and shedding occurs, that is menstruation. Okay. Estrogen is also acting on the vagina, and it is responsible for vaginal cornification, that we call it as karyotypic index. Estrogen is also acting on the cervical mucus and leads to profuse, thin, abundant, watery secretion of the cervical mucus. And also you can perform spin-Barrett test on the cervical mucus, which is cervical mucus stretchability test. So students, estrogen is responsible for menarche. Estrogen is causing changes in the vaginal epithelium, that is vaginal cornification. Estrogen causes changes in the cervical mucus. But for the hair growth, we have studied the androgens are responsible, and main source of androgens in the body is adrenal gland. So for the growth of the axillary hair and growth of the pubic hair, it is the androgen which is responsible. So the answer to this question is hair growth, which is not estrogen dependent, it is androgen dependent. Next question. A 18-year-old girl comes to gynae OPD presented with 6 months amenorrhea with low-grade fever, weight loss, pain abdomen, generalized weakness. On examination, pelvic mass felt on the left side with features of ascites. The diagnosis is ectopic pregnancy, tuberculosis of pelvis with tubo-ovarian mass, granulosa cell tumor, fibroid, uterus. Okay, so let us see 18-year-old girl with 6 months amenorrhea, low-grade fever, weight loss, pain abdomen, generalized weakness. So history is clear-cut of tuberculosis. She has not attained, she has presented with 6 months amenorrhea. So according to this, and on examination, there is the left side pelvic mass which is felt. So students, this is PID, and most probable cause in an 18-year-old girl, here it is genital TB. Most common causative agent for PID is chlamydia. Worldwide, other causes include TB, gonococcus, but since this is 18-year-old girl, so we suspect the genital tuberculosis. All PID causative agents are STD, sexually transmitted, that is ascending infection. Only genital tuberculosis, there is hematogenous spread. Hematogenous spread, that is they spread by blood. They spread by blood. So I would like to take this diagnosis as tuberculosis of the pelvis with tubo-ovarian mass. Tuberculosis of the pelvis with tubo-ovarian mass, as there is a clear-cut history, suggestive low-grade fever, weight loss, pain abdomen, generalized weakness, pelvic mass, 6 months amenorrhea, so it is TB pelvis with tubo-ovarian masses. Now, 26-year-old pregnant mother who had previous twin pregnancy visits antenatal clinic OPD for a routine checkup. she is sure of her dates with 36 weeks. What is the obstetric score in this case? See, she is presently pregnant and previously she had a twin pregnancy. So there is only history of a twin pregnancy and second time she is pregnant and it is 36 weeks pregnancy. So this is G2. That is, G means gravida. Students, gravida means number of times she is pregnant. Number of times she is pregnant. When the lady comes to you and she is pregnant, then we use the term gravida. If the lady comes to you and she is not pregnant, it is a previous pregnancy, then we use the term para. Para means parity. Para means parity, that is including the number of deliveries, stillbirths, live births, etc. So, twin pregnancy, the delivery one, although two babies are delivering, in twins, two babies are delivering or, okay, so it will be counted as only one delivery because delivery and pregnancy is one. Okay, so the life issues will be 2. So it is parity 1. Okay, G2 and P1 because delivery is only 1 and maybe if you talk about the life issues, it will be live 2. 2 living children, but delivery will be 1 as the twin pregnancy will be counted as 1. So 1 twin pregnancy and second present pregnancy, so it is gravida 2. Parity, 1 delivery has occurred, so it is parity 1 and maybe 2 living children, so L will be 2. So G2 P1. Next question. Mrs. Rekha having her child of 2 years presents with pruritus vulvae and amenorrhea. She gives history of severe blood loss and failure of lactation during pregnancy. She is lethargic. She has cold intolerance. She has multiple skin infections and anemia. What is the diagnosis? This lady delivered 2 years back and she has amenorrhea. There was a severe blood loss and failure of lactation. So what are the options given, students? Sheehan syndrome, Asherman syndrome, prolactinomas. Okay. So after the delivery, that means there was severe PPH, that the blood supply to the anterior pituitary was less. So anterior pituitary underwent necrosis, leading to decrease of the anterior pituitary hormones, which will result in secondary amenorrhea because of FSH-LH deficiency. It will result in failure of lactation, that is prolactin deficiency. Then there is cold intolerance, lethargy, there is skin infections, etc. So cold intolerance, lethargy, that is TSH deficiency, failure to lactate, prolactin deficiency, skin infections and other problems, that is because of ACTH deficiency. So this is clear-cut case of Sheehan's syndrome, postpartum pituitary necrosis. Here, treatment you have to offer to this patient. First of all, you have to give cortisol, that is steroids, and levothyroxine, that is you have to give it for lifelong. And if you want to treat amenorrhea, you have to give estrogen and progesterone. So clear cut, this is a case of Sheehan's syndrome. Next, first line of treatment of osteoporosis in a post-menopausal women. Here it is not written whether she has intact uterus or hysterectomy was done or she has normally attained menopause. Okay, so students, osteoporosis in a menopausal lady, students, the drug for hormonal replacement therapy, or the problems we usually see in the postmenopausal female, there are two lines of treatment. One is you give hormones, another one is non-hormonal treatment. In the hormonal treatment, there is estrogen, that is Premarin, for those where hysterectomy was done. And if the uterus is intact, estrogen followed by progesterone, then there is Tibolon, then there is Raloxifene. Raloxifene is SERM, selective estrogen receptor modulator, and it is also a drug to treat osteoporosis, but it should be avoided with estrogen, as Raloxifene and estrogen are known to cause thromboembolism. Now, another side effect of Raloxifene is hot flushes, and estrogen is given to treat hot flushes. So if you're giving estrogen, then Raloxifene is contraindicated because it causes thromboembolism, so that additive side effect, and Raloxifene is also known to cause hot flushes. Tibolon is testosterone derivative. It has weak estrogen, progesterone, and androgenic activity. It is also given to treat vasomotor symptoms or hot flushes. It is also to prevent or treat osteoporosis. In the non-hormonal treatment, it is biphosphonates, then calcium, then vitamin D, sachets, etc. So the first line treatment in osteoporosis is biphosphonates, that is aldronates. Okay, so I would like to mark answer here as biphosphonates. Next, this is a very straight question. Most common site for fertilization students, it is ampulla. Most common site for fertilization is ampulla. The widest part of the fallopian tube is ampulla. It is 5 centimeters. Most common site for ectopic pregnancy is again ampulla. So this is a very straight question. What is the length of the fallopian tube? 10 to 12 centimeters, which is the narrowest portion of the fallopian tube. Well, it is interstitial portion, which is 1 millimeter in diameter. 1 millimeter in diameter. Next, which of the following is not used as an emergency contraception? Emergency contraception is also called as postcoital contraception. So it is of two types: hormonal, that is to be prescribed within 72 hours of unprotected coitus, and it is IUCD, which is to be applied within 5 days of unprotected coitus. So what are the hormonal contraceptives? It is levonorgestrel, which is I pill, and dose is 1.5 milligram single dose, or it can be given in 0.75 milligram in 2 divided doses with a gap of 12 hours. Then another one is OCPs, which can be given low dose pills or high dose pills. If you're using high dose OCPs, then 2 and 2 tablets with a gap of 12 hours. And example is Ovural G, which contains gynae dose of hormones, or there can be low dose pills, which is Mala D, Mala N, Novelon, Familon, etc. And there 4 and 4 tablets with a gap of 12 hours. Then another drug is Arufuratisix, okay, which is also called as Mifepristone. And in the IUCD, there is only copper T and LNG IUCD. Mirena is not a emergency contraception. So copper T is the effective emergency contraception, because even if the fertilization has taken place, the copper T mechanism of action is prevents implantation. Okay. Now another drug for Emergency contraception is Uli-Pristal. Uli-Pristal, which is 30 mg is the dose, and it can be given within 5 days of unprotected coitus. Okay. So let us see. Ariphyretic is used. Copper T is used. High dose of estrogen also can be given, but nowadays it is not very much preferred because it is associated with side effects. Danazole is not used as an emergency contraception. Next, the distending media used in hysteroscopy with bipolar cautery. Hysteroscope is to visualize the uterine cavity. To visualize the uterine cavity. Carbon dioxide is a media which is used, but usually it is preferred for diagnostic purposes. Whenever you have to do any therapeutic, a liquid media is used. Best liquid media is glycine. Glycine, others can be Hiscon, others can be normal saline. There are so many liquid medias. So glycine is the best liquid media. Then there are Hiscon, then there is normal saline. So many liquid media can be used. Okay. But when you're doing, students, a bipolar cautery, then normal saline is the best media which is applicable for a bipolar cautery. When you're using a unipolar cautery, then even you can use glycine. Okay, so here the answer is normal saline. Next question. A 24-year-old married female for married life of 4 years visits infertility clinic with a history of recurrent abortions. On the further workup, she is found to have septate uterus, and what surgery is recommended so that the reproductive outcome is better in this case? Tompkins metroplasty, Strassman's metroplasty, Jones metroplasty, or transcervical hysteroscopic resection of the septum. So she has an infertility, or might be she is married for 4 years, maybe she's trying for a pregnancy, maybe for last 3 years or 4 years, depends. And she has recurrent abortions. Okay, so you see the most common cause for recurrent abortions in the first trimester is chromosomal, and in the second trimester is cervical incompetence. If cervical incompetence is not given in the options, another cause for recurrent second trimester abortions is congenital malformations of uterus, and most commonly it is septate uterus, and then the next one is bicornuate uterus. Okay, the best investigation of choice for Mullerian duct anomaly is MRI scan, and the gold standard investigation for Mullerian duct anomalies is laparoscopy plus hysteroscopy, because the reproductive outcome after an endoscopic surgery is much better than the open surgery. So here the best reproductive outcome will be seen after the transcervical resection of the septate uterus, whereas the Tompkins, metroplasty, Strassman, Jones, this is to be done by abdominal route, and there has to be cut in the uterus. So preferably whenever there is a pregnancy occurring, patient has to go for elective cesarean section. And reproductive outcome, if you compare the hysteroscopic resection and an open laparotomy, the reproductive outcome, students, is much better than the endoscopic surgery. That is why there is more and more focus on the endoscopic surgeries. So with hysteroscopy, you can resect out this septum and you do a guarded laparoscopy. Students, the hysteroscopic surgeries are usually done under laparoscopic guidance. so that the surgeon is aware and they should not be perforating the uterus. Another doctor is visualizing through the laparoscope, and simultaneously another advantage is with a laparoscopy, the tubal patency can also be checked. So this is the advantages here. I would like to go for a hysteroscopic resection. A sexually active female comes with a profuse, frothy, foul-smelling discharge with intense itching and strawberry cervix. So the options are candidiasis, trichomoniasis, bacterial vaginosis, chlamydia. So strawberry cervix with a profuse, frothy discharge, this clear cut goes in favor of trichomoniasis, where there is profuse, foul-smelling, creamy, green colored discharge, and on examination there is strawberry spots. Okay, so the answer to this question is trichomoniasis. Whereas in Candida it is curdy white discharge, and in Candida you make cuvette suspension and you see fungal hyphae, and the drug is antifungal, that is fluconazole and a vaginal pessary. For trichomoniasis, you have to treat both the partners. So metronidazole, oral, and the pessary are preferred. Whereas in bacterial vaginosis, again, it is a foul-smelling discharge, but you can see clue cells. There is musty odor discharge, and there is whiff test which can be performed. So that is for bacterial vaginosis. So here the answer is trichomoniasis. Next, a 26-year-old married life of 2 years visits infertility clinic. She was put on HMG, that is human menopausal gonadotropin. Human menopausal gonadotropins, which is, it is available as pure FSH or FSH plus LH injections, which is 75 and 75 international units. And now she develops dyspnea and abdominal pain, and an ultrasound report is given. So in this case, ovulation induction agent is being tried. Okay, the ovulation induction agent is usually clomiphene citrate. These are the first line ovulation induction agents. Clomiphene citrate, which is anti-estrogen, and another one is letrozole, which is aromatase enzyme inhibitor. That is also anti-estrogen in action. So both are preferred as first line drugs, and nowadays the side effects of letrozole in comparison to clomiphene citrate is less. So many studies have shown letrozole is more preferred as an ovulation induction in the first line drug. HMG, human menopausal gonadotropins, are usually considered as the second line drug. So from the history, it is not clear whether they have tried the first line drug or straight away they have switched over to the second line drug, which is human menopausal gonadotropin. And students, you know, human menopausal gonadotropin is directly stimulating the ovary. So the side effect of this is twin pregnancy in 30% cases and ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome and twins is also the side effect of clomiphene citrate, but to an extent, twin pregnancy after clomiphene is 8%, with HMG it is 30%, and the drug which causes ovarian hyperstimulation syndrome, the maximum chance is with HMG. So HMG is mostly used as an ovulation induction when you're preparing the patient for IVF techniques. Okay, so in the options, it is written as, is it polycystic ovarian disease, or this is ovarian hyperstimulation syndrome, or it is theca luteal cyst. First of all, in the PCOD, mostly the cysts are arranged in the peripheries. So here, the whole ovary contains lot many cysts. Okay, so this is no other than ovarian hyperstimulation syndrome. So management will be stop and treat the patient symptomatically. Okay, there are grades of ovarian hyperstimulation syndrome: minimal, mild, moderate, and severe. Next, the instrument used for this is treatment of ectopic pregnancy, laparoscopic sterilization, ovarian cystectomy. You can see the name of this instrument is called as laparocator. Wherever there is prongs, this is called as prongs to catch the tubular structures like fallopian tube. And there is a ring applied, which is fallope ring. That is called as celastic ring. So this is a button. We press the button, the prongs come out, we lift the fallopian tube and make sure that we have to differentiate, we have to trace till the femoral end. We should not be applying the rings to the round ligament. How do you differentiate? Round ligament is attached to the anterior abdominal wall, whereas fallopian tube, the femoral end is free. Once you're ensured that you have catch hold of the fallopian tube with the with this prongs of the laparocator, then press the button and release the rings. So this is for laparoscopic sterilization. This is called as laparocator and this is called as the prongs. Next, what condition is the mother associated with the following fetal anomaly? Can you see in this fetal anomaly? This is sacral agenesis, also called as caudal regression syndrome. And you read caudal regression syndrome is associated with diabetes in pregnancy. Diabetes in pregnancy is of two types. That is gestational diabetes, which is usually developing after 28 weeks, where organogenesis is already complete. So there is no chance of congenital anomaly in gestational diabetes, where we can control the patient on diet, and later on, if it is not getting controlled, we can switch over to insulin or oral hypoglycemic agents. Then there is a pre-gestational diabetes, where the patient is already diabetic and now she is pregnant. So the fasting, postprandial, and preconceptional sugar control is very must before she's planning a pregnancy. If the fasting or postprandial is very high, it is associated with congenital anomalies. Also, to prevent neural tube defects and congenital anomalies, folic acid 5 mg therapeutic dose should be given in these patients who are pre-gestational diabetes and planning to conceive. So the sugar control, fasting PP, and folic acid 2 months before should be done to prevent congenital anomalies. So let us see the options. Gestational diabetes, pre-gestational diabetes, ACE inhibitors, sodium valproate. Well, sodium valproate is also teratogenic. ACE inhibitors is also teratogenic, but they do not cause sacral agenesis. Now, gestational diabetes occurring after 28 weeks will not cause congenital anomalies, so it is pre-gestational diabetes. The most characteristic congenital anomaly in a baby of diabetic mother is sacral agenesis. It is rare but highly suggestive. The most common congenital anomaly in this baby is congenital heart disease. Specific for diabetes is transposition of great vessels. Overall, most congenital heart disease in pediatrics is VST. So specific is transposition of great vessels, and most common congenital anomaly seen in a baby of diabetic mother is congenital heart disease. Next, identify this image. One ring here, one ring here. So it is no other than female condom. Okay, female condom, which is called as Fem Shield. It is 15 centimeters in length, made up of polyurethane or latex material. Failure rate is 7 per 100 women year. Next, 35-year-old female comes to the gynae OPD with history of excessive bleeding since 6 months. not controlled with hormonal drugs. Ultrasound and clinical examination reveals no abnormality. Next step, 35-year-old excessive bleeding for 6 months, not controlled on whether it was hormonal drugs or it was non-hormonal drugs. I'm not very sure. I think it was non-hormonal drugs which was written in the question. So wrongly I just typed this question. Non-hormonal drugs are tranexamic acid, which is hemostatic, and it comes in a 6-tablet pack. 1 BD for 3 days is given. And another drug which is used is mefenamic acid. Mefenamic acid, which is non-steroidal anti-inflammatory drugs. It is also acting as hemostatic and anti-inflammatory and painkiller. So this patient is not controlled on non-hormonal drugs. She has excessive bleeding for 6 months. Ultrasound and clinical examination revealed no abnormality. So hysterectomy, I rule out. Even if the parity was given, I'm not in favor of hysterectomy. Hormonal therapy straight away is not recommended. Endometrial ablation is again not recommended. So before putting the patient, she is not controlled on hemostatic drug. Next line of management will be hormonal treatment, maybe progesterone or OCPs, but I would like to know about the pattern of the endometrium. Although less likely it is to be a cancerous condition, but I want to rule out the possibility of hyperplasia. So I would like to go for office endometrial sampling by using a Karman's cannula and sending the sample for histopath report. And if the histopath report comes out to be normal and all, so I would like to put the patient on hormonal therapy. So I want to know the pattern of the endometrium in this case. So I would mark endometrial sampling in this case. Next question. A 24-year-old female comes with complete perineal tear, CPT, complete perineal tear. She gave history of home delivery 2 weeks ago. Next line of management, complete perineal tear. If you diagnose within 24 hours, students repair immediately. If the patient comes 24 hours later, always it is to be repaired after 3 months, because there is a granulation tissue which is already set in. So there will be failure of the surgery. So we want to repair it after 3 months. Okay. Here I would like to mention the degrees of perineal tear, because sometimes they ask question on the perineal tear. First degree is mucosa and skin tear. Second degree is mucosa, muscle and skin tear. The modern mediolateral episiotomy is a planned second degree perineal tear. Students, please remember. Third degree is anal sphincter tear. So many times they ask the degrees of tear. And fourth degree is anal canal tear. So median episiotomy, which was given in olden times, is first degree perineal tear. Mediolateral is second degree. Third degree is anal sphincter, and fourth is anal canal. Next, a pathogram of a pregnant lady was given, and they have asked, what is it showing? CPD, inadequate uterine contraction, prolonged latent phase, or none? Student, this is a WHO modified pathogram. WHO modified, how do you differentiate? There is no latent phase in WHO modified pathogram. Okay, and the plotting starts with 4 centimeters of cervical dilatation. So alert line is plotted from 4 centimeters. There is alert line, action line. There are 3 zones. So pathogram, there is a maternal monitoring, fetal monitoring, labor monitoring. Maternal information, there are 5 components of Pathogram. The maternal information, the fetal well-being, the labor progress, the IV fluids, and the maternal monitoring and the medication. So there is an alert line, action line. There are 3 zones. The cervicogram is a part of a modified WHO Pathogram. Cervicogram, you're only plotting the active stage of labor. There is cervical dilatation and descent curve. So the exact figure which was given there, it has entered in zone 2. The zone 1 is progress normal, zone 2 is progress slow, and zone 3 was obstructed labor. So there is a line which was given, which was going from 4 centimeter till has reached to 10 centimeter, and the descent was not occurring. So purple line was the one which was given in the exam. So you can see the contractions are adequate in this case because cervical dilatation is full. There is no latent phase which is being mentioned. Okay, so it is a clear-cut case of CPD where there is arrest in descent of the head. Okay, details of the Pathogram I will take up a separate video where I will discuss. Okay, so this was CPD, cephalopelvic disproportion. Now identify the image. This is an image of hysterosalpingography. Hysterosalpingography is an important investigation for 2 things: for uterine pathology like septate uterus, bicornuate uterus, or for Asherman syndrome, and it is also a tubal patency test, although it is first line in both the cases. So this is showing a radiopaque dye is put and you can see the uterus is almost normal. The tube here on both the sides is normal, and here you cannot see. The 3 films are taken, number 1, number 2, and number 3. You don't see any free spill. So there is no free spill in this case, and the femoral end is enlarged. So it is bilateral hydrosalpinx. Bilateral hydrosalpinx, that is a type of PID. Okay, so confirmatory here will be, you can go for a laparoscopy, but students, when that HSG is showing clear-cut bilateral tubal block, so it's better you either decide to go for operative or you decide to give a best treatment to the patient, which is IVF. If she wants to take up a chance, then laparoscopy combined with hysteroscopy can be tried to open the block tubes, but I would say the IVF will be a better option in treating infertility in this case. The HSG oil-based dye is preferred because picture is very, very clear. In HSG, it is done in the follicular phase, that is immediate post-menstrual phase. And what is the instrument used in this case is Leash-Wilkinson cannula. This is very, very important for you to remember. Leash-Wilkinson cannula. So here the HSG image shows bilateral hydrosalpinx. Next, a 40-year-old female visits gynae OPD with history of intermenstrual bleeding. Intermenstrual bleeding is acyclical bleeding. That means she's having periods, in between she's having the bleeding. Intermenstrual bleeding, you should try to rule out the cancers, mostly the endometrial cancer, or there can be endometrial polyp, etc. So the ultrasound image is given and it is showing like this. Can you trace this? And there is a feeding vessel. Ultrasound which showing a lesion like this and a feeding vessel is usually endometrial polyp. So the next line of management will be hysteroscopy, and hysteroscopic resection of this endometrial polyp will be the best treatment in this case. So this is clear-cut case of endometrial polyp where there is a feeding vessel is endometrial polyp. So hysteroscopy will be the best. Number one, it will confirm your diagnosis. Number two, you can therapeutically treat the hysteroscopy resection. Next, a mother with 7 weeks of period of gestation presents in the antenatal clinic with accidental exposure to the radiation. What is the advice in this pregnancy? A lady has 7 weeks pregnancy and accidentally she has exposure to radiation. Deliberately it was not there. So what will you do? You are going to terminate the pregnancy, you are going to continue the pregnancy, you are going to check the chromosomal anomalies or pre-invasive diagnostic test. Students, the acceptable radiation is up to 5 rads. If there is an accidental exposure, so it must have been very, very less radiation. So the Williams textbook of obstetrics says that continue the pregnancy. Continue the pregnancy. Next, 13-year-old attends gynae OPD, has not attained menarche with karyotype of 46XX. On examination, there is a clitoromegaly. And what is the enzyme deficiency responsible for this? Clitoromegaly 46XX. So this is, like congenital adrenal hyperplasia, and the most common enzyme deficiency is 21 alpha hydroxylase. So what is happening is, in this case of congenital adrenal hyperplasia, which has got two onset, the early onset or the late onset, and it is a most common cause of ambiguous genitalia. It is a most common cause of virilization in the female child. Karyotype is 46XX. The uterus is there, the ovary is there. Only thing is, in the intrauterine life, there is there is a deficiency of this enzyme. So the more of the androgens are being produced, and androgens is responsible for ambiguous genitalia and later on virilization in the female child. So the most common enzyme deficiency is 21 alpha hydroxylase. Next is 11 beta hydroxylase. Next, causative agent for donovenosis is Calymatrobacter granulomatis. Next, serum prolactin is highest in. This is a clear-cut line written in your undergraduate textbook that prolactin is high after 24 hours of parturition. So it is your basic question from your physiology. So when is the serum prolactin levels highest? It is 24 hours parturition, because suddenly there is a fall of the estrogen progesterone hormone levels. Episiotomy incision extended posteriorly beyond the perineal body. Which structure is damaged? So it is the external anal sphincter. Next, in the female, the remnant of Wolfian duct is present in the leaves of the broad ligament. Wolfian duct in the males give rise to seminal vesicles, vas deferens, and epididymis. In the females, it presents as Gartner's duct and Wolfian body. Remnant is apophoron and paraphoron. So these lies in the leaves of the broad ligament. This is vestigial, has got no role. Sometimes this is enlarged and it forms a big cyst. So sometimes it might have to be removed. Highest oxygen content in the fetal circulation is in the inferior vena cava. highest oxygen content in fetal circulation is in the inferior vena cava. 22-year-old comes to OPD. She is primigravida, very sure of dates at 20 weeks of pregnancy, and on examination fundal height comes out to be 16 week size. Ultrasound shows reduced liquor. Reduced liquor, and she's very sure of the dates. The fundal height discrepancy is there. So this is oligohydramnios, and an important cause of oligohydramnios is renal agenesis. Next, a 55-year-old woman is diagnosed to be a cancer cervix stage 2B. Cancer cervix stage 2B. For the stage 2B, stage 3, and stage 4, you give concurrent chemo radiation. Concurrent chemo radiation. Okay. And radiosensitizer drug in cancer cervix is cisplatin. Let us see which statement is true. Small bowel is most radioresistant. Students, wrong. It is very sensitive to radiation. Small blood vessels are most radioresistant. No, they are very sensitive. Rapidly proliferating cells are again radiosensitive. The dose of the radiation is inversely proportional. Dose and intensity is inversely proportional to the square of distance of the source. Yes. So the correct answer is this. So that's all. Thank you and all the best.